There was a problem with certain patients who participated in the study, especially adults that were critically ill, and they ran a very high risk for death. And apparently, within these subgroups, there was not an apparent proof that the patients benefited from the use of Zigris. Now, the lack of that confirmatory data from placebo-controlled trials caused the question about the validity of the study and the efficacy of the drug. DAA, though, received marketing authorization from the European Medicines Agency for the treatment of adults with severe sepsis and multiple organ failure, but the approval was subject to annual review. In 2007, the agency concluded that sufficient doubt existed to warrant a new placebo-controlled trial. So another trial was conducted to test the hypothesis that Zigris, as compared with placebo, would reduce mortality in patients with septic shock. So the primary outcome of these 1,680 patients, 99% was evaluated. It was a large international study involving critically ill adults with septic shock. The lack of benefit was consistent across predefined subgroups. The strength of the trial lie both in its design and its execution, and from the results of previous randomized trials, a clinically relevant population of patients was identified who were likely to benefit, and a limited number of relevant subgroups within the population was predefined as well. The baseline of protein C levels were markedly reduced in many patients, and all patients remained dependent to vasopressors, and also they were treated with norepi. To reduce bias, assignment bias, the study group assignments before and after randomization were concealed, and to minimize crossovers, a standardized process to select hospitals and intensive care units, ICUs, that did not regularly treat patients with Zigris were used. Mortality was used as an outcome that is less subject to biased ascertainment than other outcomes, and the focus was on mortality at 90 days, since 45% of the patients were still hospitalized at 28 days, a percentage similar to that reported by the Prowess study. Since mortality was the main modulator that basically determined whether the study was successful, actually in the placebo group it was low as compared with historical data, but consistent with what was observed in more recent observational studies and trials. A resolution of organ failure in pediatric patients with severe sepsis trials showed that Zigris did not reduce mortality in children or adults with severe sepsis who had a low risk of death. Now, these results were consistent with the finding in the ADDRESS trial, and in that Zigris was not effective in patients with an increased disease severity. And since there was no explanation for the inconsistency between the current findings and the reduction in mortality at 28 days that was observed in the Prowess study, after that, the FDA deemed that maybe Zigris was not the drug that was portrayed to be. Because of that inconsistency of the data, there were a lot of pivotal trials that were performed. Unfortunately, the trial in question, the original trial in question in phase 3, was deemed unnecessary, and they had to wrap it up prior to finishing all the documentation and all the work that needed to be done. Subsequent pivotal studies, as I said, they were done. They were also cut very short due to the lack of results from on the phase 3 trials. And They led to the subsequent withdrawal of the drug from the market. There were also pivotal studies, attempts to show relevance of usage of Zigris with other pathology. As for example, we have this pivotal study by Demphley and et al. And in their study, they want to prove that the use of Zigris along with enoxaparin on patients presenting with pulmonary embolism, that was back in 2010, was conducted, and there was no published data on the subject prior to that. This was a double-blind clinical trial. 47 patients, they all had commuted CT confirmed acute submassive pulmonary embolism. They were treated with 1 milligram per kilogram body weight of enoxaparin and twice daily, were randomized to groups receiving a 12-hour intravenous infusion of Zigris, and blood samples were drawn before starting the infusion and after the 4, 8, and 12 hours, and on the treatment of days 2, 3, 4, 5, and 6. Patients who exhibited increased levels of D-dimer indicating a high level of acute fibrin formation and dissolution, Zigris infusion resulted in a more rapid drop in soluble fibrin, D-dimer, and fibrinogen degradation products. And the levels, as I said, they were compared to enoxaparin alone, and there was a parallel decline of soluble fibrin, D-dimer, FDP, and plasmin-plasmin inhibitor complex in response to treatment with enoxaparin plus Zigris, with no evidence of a systemic profibrinolytic effect of the treatment. As a result of all these results, it was deemed that further studies are needed to investigate a potential clinical benefit related to application of Zigris in acute thromboembolic events, and a longer time frame of Zigris application might result in more pronounced effects. Primary and secondary outcomes, according to the FDA, primary outcome was death at 28 days. Secondary outcomes included 28-day mortality in patients with severe protein C deficiency. And after examining the heterogeneity of the treatment